No response.
Understand.
No, it did not work. It does not work at all. So I can share my slide from the sharing. No. どうして動かないんでしょうか。なんか、さっき動いたのに。So could you tell me what I should what I should do for the sharing my slides? 次
すみません。私だけやりましょうか。で、その間に吉本さんのデータ、鈴木先生のパソコンから入れて、
はい。
これでどうでしょうか。
わかりました。はい。
We are very sorry. She cannot present at this moment. So that let's move to the second speaker. Second speaker, Dr. Masaru Takeshita. He is a rheumatologist and assistant professor of rheumatology in Keio University. After completing his medical education in 2007, and he engaged in the clinical practice, and he earned a PhD in Keio University Graduate School of Medicine. His major research interests are pathogenesis of human autoimmunity, autoantibody, and translational research, including rheumatoid arthritis and Sjogren syndrome.
Yes, I can do that.
He has many awards and many research funds. So the time is yours. Please start your presentation, Dr. Takeshita.
The chance, and please shut off this slide. Okay, and I will share my slide. How is it? Is it okay?
Okay, I can see.
Okay. So thank you for your chance to present about advances of autoantibodies of Sjogren syndrome. I'm Masaru Takeshita, and I'm working mainly for traditional research. Autoantibody is one of my recent research topics. In this session, first I'd like to present an overview of autoantibodies in Sjogren syndrome, and then present about our recent studies about autoantibodies in Sjogren syndrome. This is the newest classification criteria for Sjogren syndrome, published in 2016 from ACR and EULAR. These criteria has inclusion criteria and exclusion criteria. And after that, a cutoff of 4 or more points is used for classification for Sjogren syndrome. The items are showing. There is only one criterion for autoantibodies, anti-SSA low antibody positive, and it has 3 points, relatively important item among the criteria, indicating that anti-SSA antibody positive patients are more likely to present a series of symptoms typical of Sjogren syndrome. It has been reported that a wide variety of autoantibodies, in addition to anti-SSA antibody, are observed in patients with Sjogren syndrome, although most of them are not included in the criteria. Anti-SSA low and anti-SSB LAR are most famous autoantibodies in Sjogren syndrome. These two antibodies are the first autoantibodies found in Sjogren syndrome in 1975, as Sjogren syndrome antigen A, SSA, and Sjogren syndrome antigen B, SSB. But later, anti-SSA antibody was found to be two different autoantibodies, anti-Rho 60 antibody and anti-Rho 52 antibody. A rheumatoid factor is usually detected in patients with rheumatoid arthritis, but it is also observed in patients with Sjogren syndrome. Anticentromere antibody, which is thought to be an autoantibody for systemic sclerosis, and anti-mitochondrial antibody, which is thought to be a primary biliary cholangitis, are also observed in Sjogren syndrome as well. Anti-M3 receptor antibody is considered to be an antibody that blocks carnic-3 receptors that stimulate saliva secretion in salivary glands epithelium. Anti-alpha fodrin antibody is found in the mouse model of Sjogren syndrome, and it is also detected in patients with Sjogren syndrome. Many other autoantibodies have been reported, but not discussed here. We focused on the major antibodies. Here we summarized about anti-SSA antibody, which is the most well-known and is included in the classification criteria. As I mentioned before, anti-SSA antibody was found to be two different autoantibodies. One is anti-Rho 60 antibody. The corresponding antigen is Rho 60, 60 kilodalton protein TROB2 ribonucleoprotein, which forms complex with yRNA. This molecule mediates the quality control of misfolded non-coding RNA. This protein is known to be very difficult to produce in mammalian cells. Another antibody is anti-Rho 52 antibody. Target is 52 kilodalton TRIM21 protein, which is an E3 ubiquitin ligase and has also function as cytosolic IgGs via IgG-Fc. In most cases, E. coli-derived proteins are used for immunoassays to detect autoantibodies, such as for ELISA. Unlike protein derived from mammalian cells, proteins from E. coli do not have post-translational modifications, such as SS binding or glycosylation, and their 3D structures are not correctly folded. For example, Rho 52 protein from mammalian cell cannot be used as an antigen for ELISA because all antibodies bind to Rho 52 due to its Fc receptor function. But Rho 52 from E. coli has no Fc function and can be used for ELISA. Anyway, Rho 60 and Rho 52 are different proteins, and clinical significance of anti-Rho 60 and Rho 52 antibody differs as well. It is reported that 93% of Rho 60 positive, Rho 52 positive patients had autoimmune diseases, among which SLE and Sjogren syndrome were the most common. Rho 60 positive but Rho 52 negative patients were mostly autoimmune diseases as well as double positive patients, and mostly SLE and Sjogren syndrome. Rho 52 positive but Rho 60 negative patients differ slightly from others, which is an increased proportion of non-autoimmune diseases and with more arthritis and myositis and less SLE. These results indicate that the anti-Rho 60 antibody seems to be more relevant to SLE and Sjogren syndrome. However, the 2016 classification criteria for Sjogren syndrome does not distinguish between anti-Rho 60 and Rho 52 antibodies, and I think it may change in future. And the second major autoantibody is anticentromere antibody ACA. ACA is a major autoantibody detected in limited cutaneous systemic sclerosis and primary biliary cholangitis, and used in the classification criteria for systemic sclerosis, but not included in the classification criteria for Sjogren syndrome. ACA sometimes overlapped with SSA, and in our hospital, About half of ACA-positive patients were positive for SSA. And ACA-positive patients has different phenotype from SSA-positive patients. As shown below, Raynaud's phenomenon and sclerodactyly and lower prevalence of lymphoadenopathy, extragrandular manifestation, and hyper-IgG and RFs in ACA-positive patients. As we have seen, autoantibodies are one of the most useful clinical tests, but there are many scientific questions about autoantibodies that are not well understood. The targets of autoantibodies in systemic autoimmune diseases are nuclear or cytoplasmic proteins that cannot be accessed by antibodies. So what are autoantibodies doing? In addition, why do autoantibodies appear in some people? Why are certain autoantibodies associated with certain diseases? And where are the autoantibodies produced? These questions have not yet been fully answered, but a small portions of answers have been revealed through detailed examination of disease lesion in Sjogren syndrome, and I will present next. The research background. The existence of anti-SSA and anti-SSB antibody secreting cells in salivary glands of Sjogren syndrome have been suggested 30 years ago, such as IgA type anti-SSA and anti-SSB antibody are secreted into saliva. Anti-SSA and anti-SSB antibody producing cells exist in salivary glands, and anti-SSA, anti-SSB, and other autoantibodies are produced in salivary glands of 2 patients are reported. But however, the reports were fragmented with only a few cases, and we wanted to know what was really going on. Therefore, we started the research to investigate the B-cell immune response in salivary glands of Sjogren syndrome comprehensively. The results were reported in these 2 papers. The methods. We sorted the antibody secreting cells from lip biopsy tissues as single cell and sequenced variable region of antibodies and created expression vectors and produced recombinant monoclonal antibodies. Then we checked antigen specificity of them by ELISA, mass spectrometry, and antigen binding beads assay. To examine specificity of antibodies, we used antigen binding beads assay. Recombinant antigen were immobilized on the beads using protein tag, and binding ability of tested antibody was detected by second antibody with fluorochrome and analyzed by flow cytometry. This is patient's background. 9 patients were recruited, and half of them were serum anti-SSAB positive. Only 1 patient was ACA positive. From them, we recruited a total of 256 antibodies. First, we checked antigen specificity of these antibodies against SSA and SSB. SSA row 60, SSA row 52, and SSB. As you can see, all kinds of autoantibodies were found, and the frequency of autoantibody producing cells among cells from salivary glands were around 30% high in serum anti-SSA and serum anti-SSB antibody positive patients. No SSA antibody and SSB antibody was observed from salivary gland of serum anti-SSA the negative patients. Next, we focused on ACA. We generated 39 antibodies from 1 ACA positive patient. And we examined by ELISA for anti-CEMP-B antibody, the major antigen of anticentromere antibody, but no antibody was considered as anti-CEMP-B antibody. Therefore, we examined the target of these antibodies by immunoprecipitation. This is the result of immunoprecipitation. Left lane was antibody only, and right lane was antibody incubated with cell lysate. Several proteins were immunoprecipitated, and MS identified these proteins were DSN1, Wnt, NSL1, and so on. According to previous reports, these are members of large protein complex KMN assembly, which has 3 subcomplexes located at centromere region. Next, we have to confirm which protein the antibody bound to. We immobilized each protein on beads and incubated with antibody. This antibody slightly bound to DSN1, NSL1, MIS12, and TMF1, the members of MIS12 complex, and strongly bound to whole MIS12 complex. Therefore, this antibody recognizes the 3D structure of MIS12 complex, which is the novel target of ACA. Next, we checked the reactivity of our antibodies by this assay against MIS12 complex and other known targets of ACA, including CBX5, TEMP-A, and C, and found that TEMP-C and MIS12 complex are major targets of ACA in salivary glands. Interestingly, one serum ACA negative patient, LB02, generate many ACAs only in salivary glands. These results suggested that ACA can be produced in salivary glands as well as anti-SSA and anti-SSB antibody. So we have next question. We found that MIS12 complex is one of the targets of ACA, but in recent years, the structure of centromere has become clearer. This is the schematic of centromere. The center of chromatin is called centromere region, and it bound to microtubule via kinetochore. Many proteins are involved in this part. We found that this red area are the targets of ACA. So what about the others? To review this, I asked Dr. Kajio, a graduate student at that time, to make all the centromere and kinetochore proteins as recombinant proteins, and to examine serum titers of patients with Sjogren syndrome, systemic sclerosis, primary biliary cholangitis, and their overlaps, and healthy control. This is the titer of each protein, healthy control, Sjogren syndrome, sclerosis, PBC, and disease overlapped. And the dotted line is cutoff. In addition to the known CBX5, SEMP-A, B, C, and MIS12 complex, many other proteins were found to be the targets of ACA. This is the result of clustering analysis using serum antibodies and patient disease. This reveals that some of these proteins are major targets of high frequency, and some are minor targets that are not. The participants are colored by diseases seem to be classified into 3 groups. Cluster A had broad spectrum of antibodies, cluster B had some antibodies, and cluster C had few or no antibodies. Although patients with overlapping diseases tended to be classified as cluster A, other disease specificities were not consistent with clusters. The summary of the result and discussion. Anti-SSA and SSB antibodies and ACA are produced in salivary glands of Sjogren syndrome. ACA recognizes various portions of centromere and kinetochore proteins, regardless of disease. It is known that serum ACA positive patients have some common symptoms, such as Raynaud's phenomenon and sclerodactyly, different with anti-SSA positive patients. So we think autoantibody profile and disease classification around ACA is a future matter. One way is shown in left, that Sjogren syndrome has 2 autoantibodies. One is SSA and one is ACA, and these patients have different phenotype. ACA is also observed in systemic sclerosis and PBC. Another way is that showing right side, that ACA is not an antibody for Sjogren syndrome, but separate disease, for example, ACLAR-related diseases. This disease presents one or more symptoms of dryness, symptom of SSP, symptom of PBC. The results of recent study have revealed some of the answers to questions about autoantibody, where the autoantibody produced. We show that anti-SSA, SSB, and ACLAR are produced in salivary glands of Sjogren syndrome. And other group showed that B cell in joint of RA patient produced ACPA. We also reported that anti-SSA-B antibody and anti-RNP antibody and ACPA and RF are produced in lung region of patients with interstitial lung disease complicated with Sjogren syndrome, MCTD, and RA. In addition, anti-ALS antibodies and anti-Rho52 antibodies are produced in lung region of patients with anti-synthetase syndrome. Therefore, autoantibodies may be commonly produced in disease region. We would like to continue the research on how autoantibodies are produced. Thank you for your listening.
Thank you very much, Dr. Takeshita. The very, very nice presentation and very interesting topics. He introduced anti-SSA and SSB antibody and anti-ACLAR, and he also showed recent data from his research. Thank you very much. Later, we ask you some questions. So thank you very much.
Thank you very much.
Next, we go back to Dr. Yoshimoto's presentation. Dr. Yoshimoto is ready. Time is yours. Let's start your presentation.
Do you see my slide?
Yeah.
Okay. Is it okay? Okay, thank you very much. So I feel so sorry for my trouble of my slide sharing. So let me start my presentation. So I'm Keiko Yoshimoto and working at the research lab of a division of rheumatology in the Keio University School of Medicine. So first of all, I would like to say thank you for giving me this opportunity to present our work at this conference. Today, I'm going to present our work about the involvement of BAFF, B-cell activating factor, and monocyte in the pathogenesis of Sjogren's syndrome. We have nothing to disclose. We have been working on the project about the involvement of B-cell activating factor, BAFF, in the pathogenesis of autoimmune diseases in which B-cell activation is involved, such as Sjogren's syndrome. BAFF is a cytokine, and it is well known as an important player in proliferation, differentiation, and survival of B cells. As shown here, BAFF usually forms, trimer and sometimes forms sextamer and binds its receptors expressed on immune cells, such as B cells, activated T cells, monocyte, and so on. BAFF has three types of receptors, such as BR3, CASI, and BCMA. Here are the characteristics of three receptors, and they are expressed on many kinds of cells, many kinds of immune cells. Particularly, B cells are mainly expressing these receptors. They have their own ligands and transcription factors and functions as shown in this table. We focused on BR3 because it is only the receptor which specifically binds to BAF. BAF has many functions through BR3 as shown in this slide. Basically, BAF is produced by many types of cells, such as monocyte, macrophages, and dendritic cells, and B and T cells. It is well known that major BAF-producing cells are monocyte, dendritic cells, and macrophages. When BAF binds its receptor BR3, BAF shows activating functions on immune cells. So BAF and BR3 play an important role in the activation of immune systems and in the pathogenesis of autoimmune diseases. We first focused on the Sjogren syndrome, SS hereafter, as a target disease of our study, because BAF plays an important role in the pathogenesis, and it is one of the therapeutic targets of this disease. SS is one of the autoimmune diseases, and the major symptoms of this disease are dry mouth and dry eyes because of the infiltration of lymphocytes into the organs, such as lacrimal glands and the salivary glands. This disease is often accompanied with hypergammaglobulinemia, and the serum levels of autoantibodies were elevated in the patient, suggesting that abnormally activated B cells are involved in the pathogenesis of this disease. Many lines of evidence showed that BAF and B cells are involved in the development of autoimmune diseases such as SS. For example, elevated serum level of BAF was correlated with that of autoantibodies of the patient. In addition, gland of the patient. Proportion of peripheral B cell subset of SS patients were quite different from those of healthy controls. We have published that the proportion of activated B cells, CD38 high IgD positive cells, was elevated in peripheral blood and correlated with clinical parameters of the patient. BAF and its receptor BR3 axis also plays an important role in SS. It is well known that BAF accelerates activation and proliferation of B cells through BR3. In addition, we found that peripheral monocyte from SS patient showed robust increase in the IL-6 production upon the stimulation with BAF in vitro. So based on this background, we presume that abnormal activation of B cells and monocyte by BAF is responsible for the pathogenesis of SS. First, we looked at the expression level of BR3 in monocyte by FACS. This slide shows the representative data of BR3 expression in peripheral monocyte from SS patient and healthy control. We stained the cells with anti-CD14 and anti-BR3 antibodies in whole blood samples and gated monocyte area and looked at the expression level of CD14 and BR3. So as we can see here, the expression level of BR3 in peripheral monocyte was elevated in the red square, elevated in SS patient compared to the healthy control. PSS means primary Sjogren syndrome, which means no other autoimmune diseases accompanied. Then we measured the proportion of CD14 positive monocyte among peripheral white blood cells and expression level of BR3 in the CD14 positive monocyte in 67 SS patients and 37 healthy control. Left panel shows the proportion of CD14 positive monocyte was significantly higher than higher in the SS patient as compared to the healthy control. Then we quantitatively analyzed the proportion of BRC positive cells among peripheral CD14 positive cells, BRC positive CD14 positive ratio in whole blood from SS patient and healthy control. Right panel shows that the proportion of BRC positive monocyte was significantly higher in SS patient than in healthy control. Then we compared the BRC positive CD14 positive ratio among autoimmune diseases such as systemic lupus erythematosus, SLE, and rheumatoid arthritis, RA. As shown in this slide, the BRC positive CD14 positive ratio was significantly higher in SS patient than those of SLE patient and RA patient. In addition, no significant differences in the ratio were observed between SLE and healthy control and RA and healthy control. This data suggests that the increased BRC positive CD14 positive ratio is likely to be SS specific. So we have reported that SS monocytes showed a robust increase in IL-6 production upon stimulation with BAFF in vitro. We demonstrated the relationship between BR3 expression and IL-6 production in monocyte stimulated with BAFF. We prepared peripheral monocyte and cultured the cells with BAFF for days, and the amount of IL-6 in the culture supernatant was measured by ELISA. As shown in the left panel, SS monocyte showed a significantly higher production of IL-6 than normal monocyte upon stimulation with BAFF. In addition, the amount of IL-6 produced by SS monocyte upon stimulation with BAFF positively and significantly correlated with the BRC positive CD14 positive ratio, as shown in the right panel. This data suggests that IL-6 production was induced by BAFF-stimulated monocyte, mainly via BR3. We next examine whether elevated expression of BR3 in SS monocyte correlated with the clinical features of SS that were involved B-cell activation. As shown in this slide, we found a positive and significant correlation between the BRC positive CD14 positive ratio and serum IgG levels of the patient and IgM level of the patient. And then we investigated the possible involvement of BRC positive monocyte in the production of autoantibodies such as anti-Rho SSA and anti-La SSB antibodies. As shown in this slide, the BRC positive CD14 positive ratio was significantly higher in serum anti-Rho SSA positive and anti-La SSB positive than anti-Rho SSA negative and anti-La SSB negative patients. Our data raised the possibility that elevated expression of BR3 in monocyte contribute to a B-cell activation and the production of autoantibodies. Then we demonstrated the correlation between BRC expression in monocyte and ESS dye score, which stands for disease activity of SS patient. Notably, we found that the proportion of BRC positive monocyte, BRC positive, CD14 positive ratio was positively and significantly correlated with the patient ESS dye score. So our findings indicate that BRC positive monocyte play an important role in B cell activation and in the pathogenesis of SS. So to elucidate the mechanisms of the contribution of BRC positive monocyte to B cell activation, we cultured peripheral B cells with autologous monocyte with or without BAF by using transfer insert in a well, as shown in this slide. So cells cannot contact with each other in the system. We prepared B cells and monocyte from whole blood samples and co-cultured the cells with or without BAF. The amount of IgG produced by the cells in the culture supernatant was measured by ELISA. The expression of B cell surface markers such as CD19, CD38, and IgD were analyzed by FACS. This slide shows the representative FACS data of expression of B cell surface markers on SS B cells co-cultured with monocyte in the presence or absence of BAF. First, we gated CD19 cells, 19 positive cells, and then we determined the cells which were CD38 positive, IgD negative cells in the red square as a mixture of plasmablasts and plasma cells. As shown here, plasmablasts and plasma cells were increased by adding monocyte into the culture, and the BAF dramatically enhanced the proportion of these cells. So then we measured IgG in the culture supernatant by ELISA. As shown in this slide, monocyte significantly enhanced IgG production by B cells, even without BAF stimulation in the blue column. Notably, BAF levels increased in IgG production by B cells co-cultures with monocyte in the red column, and the amount of IgG produced by the cells was significantly higher in SS patients than that of healthy control. As I mentioned, since BAF-stimulated SS monocyte produce significantly higher amount of IL-6 as compared with normal monocyte, so we added anti-IL-6 receptor antibody to normalize IL-6 into the culture. As shown in this slide, addition of an anti-IL-6 receptor antibody to the co-culture system significantly inhibited IgG production, whereas the control IgG did not suppress that production. Taken together, we presume that factors such as IL-6 produced by BAF-stimulated monocyte mediate IgG production by B cells. This slide summarizes our hypothesis about possible involvement of BAF, BRC, and monocyte in B cell activation and IgG production. BAF is mainly produced by monocyte and macrophages or dendritic cells and binds its receptors on B cells. We found that monocytes themselves also express BR3, and IL-6 production was induced in monocyte upon stimulation with BAF. We presume BAF and IL-6 synergistically activate B cells to produce IgG. So these are our take-home messages. Our data suggests that accelerated signal transduction through a BAF-BLC axis in monocyte is involved in B-cell activation and associated with clinical parameters of SS patient. Our findings raise the possibility that the BAF signaling pathways through BL3 are the possible therapeutic targets for SS. At the end of my talk, I sincerely thank to all the members of our lab, Regulation Immune Cell Functions Lab, Asuka, Mitsuhiro, Sho, Walid, Shuhei, Noriyasu, Hideto, Kunio, Kenji, for their great support. Thank you very much for your kind attention, and thank you very much for sharing our work with me today. Thank you very much.
Thank you very much, Dr. Yoshimoto. The beautiful and clear presentation of the research in the Sjogren syndrome. Especially, she focuses on BAF and monocyte. The BAF is so the important mediator of the Sjogren syndrome, especially B-cell activation. So she also shows the IL-6 importance and BAF receptor importance in the BAF axis and B-cell activation. Very interesting. So I have many questions. So in the panel discussion that we discuss more about her presentation. So thank you very much, Dr. Yoshimoto, the very wonderful presentation.
Thank you very much.
ミュートになってます。
ミュート、失礼しました。I'm very sorry. Dr. Yoshimoto was very nice presentation, and we would like to discuss her presentation in the last panel discussion. Thank you very much, Dr. Yoshimoto. And sorry, let's move to the next presentation. We invited Dr. Jun Kikuchi. I briefly introduce him. Dr. Kikuchi is a rheumatologist and assistant professor of rheumatology in Keio University. He is also a fellow of Japanese Society of Internal Medicine and board certified member, counselor of JCR. After completing his medical education at Keio University in 2007, he served as a fellow and instructor of internal medicine and rheumatology, and he earned his PhD focusing on peripheral immune cells in patients with rheumatoid arthritis. Now he is serving mainly as a clinician and researcher in clinical care and mentor of medical students in our division. His major research interests are pathogenesis, translational research, and clinical research for autoimmune diseases, including rheumatoid arthritis and systemic lupus erythematosus. And today, his talk title is Clinical Management and Case Study. Dr. Jun Kikuchi, the time is yours.
Thank you very much, Dr. Suzuki, for the kind introduction, and thank you very much for the secretary and staffs in this APLAR Academy. Okay, I'll share my slides. Okay. Can you see my slide?
Yes, we can.
Okay, thank you. I'm Jun Kikuchi from Keio University. I'm a rheumatologist, and it's my pleasure to give this lecture in this course. And today I'd like to talk about clinical things, and I'd like to introduce my case experience and share my experience. And at first, I'd like to introduce.
Boleh putar balik gini, atau bukan putar, masuk gang sebelah nanti.
Okay.
Yeah, okay.
I'd like to introduce
Yeah,
my
makasih.
institute, Keio University Hospital. This hospital is in Shinjuku, Central Tokyo. This is the National Olympic Stadium, and this is National Park near this hospital. Recently, the main entrance building has been renewal, and many patients gather every day. Okay, let's move on to the lecture. This is the overview. Sjogren syndrome is very heterogeneous, so I will focus on some main manifestations in this lecture. Sjogren syndrome is a systemic autoimmune disease with mainly dry symptoms and a variety of extraglandular manifestations, as well as glandular symptoms. According to Japanese report, extraglandular manifestations are present in 25% of primary Sjogren syndrome. In Japan, it is designated as an intractable disease and is covered by medical subsidies if diagnostic and severity criteria are met. In 2017, Japanese Society of Rheumatology published clinical practice guideline for Sjogren syndrome. This guideline refers management for clinical symptoms like dry mouth and dry eye, in addition to examination findings and complications. After diagnosis of primary Sjogren syndrome, we think about glandular form and extraglandular form. At first, we focus on dry mouth and dry eye. For dry mouth, the guideline recommended cevimeline and pilocarpine as they can improve salivary secretion and dry mouth, and also some herbal medicine, including bakumondoto in Japanese, byakkoka ninjinto, in addition to oral moisturizing agents. A randomized controlled trial of cevimeline in Sjogren syndrome patients with xerostomia and keratoconjunctivitis sicca showed better response in the 30 milligram cevimeline 3 times daily groups. For example, about 70% response. However, adverse events like nausea, increased sweat, and diarrhea were observed in about 15 to 20% of the patients. Pilocarpine was also showed a significant response for dry mouth by randomized control trial with 70% response. Both drugs act by binding and activating muscarine-3 receptors, resulting in increased secretions from exocrine glands, including the salivary and sweat glands. The contraindications are shown here, like serious ischemic heart disease, bronchial asthma, and obstruction of gastrointestinal tract and bladder neck, and so on. Therefore, some patients avoid these pharmacological stimulation and use non-pharmacological approach. It is considered that systemic administration of glucocorticoids cannot improve glandular lesions. According to the results of randomized controlled trial and risk-benefit balance, they do not recommend also hydroxychloroquine or immunosuppressive agents for glandular lesions. The EULAR recommendation for Sjogren syndrome published in 2019 also refer the pharmacological and non-pharmacological stimulation for glandular dysfunction, shown here. As you know, to evaluate systemic disease activity in clinical trials, as well as daily clinical practice, we can use standardized instrument, ESSI. It includes 12 organ domains, which are divided into 3 to 4 levels of disease activity. ESS-PRI ESPRI is a very simple index designed to measure patients' symptoms in primary Sjogren syndrome. It consists of 3 scales: dryness, fatigue, and pain. We can use these instruments also to evaluate disease activities or monitoring treatment response. Among ESS-DI organ domains, there are potential life-threatening systemic manifestations in severe forms, includes a severe form of cutaneous domains, pulmonary, renal, muscular domains, and peripheral and central nervous system domain, and hematological domain. Other than ESS-DI organ domains, we should consider the complications negatively affect prognosis. Malignant lymphoma, together with hematological malignancies, primary biliary cholangitis, autoimmune hepatitis, and pulmonary artery hypertension. So I'd like to focus on some extraglandular manifestation with case presentation. First case is 75 years old female. Chief complaint was dyspnea of exertion and dry cough. She started feeling dry eye and dry mouth from 2009 and was diagnosed of primary Sjogren syndrome by positive Schirmer test, fluorescent test, gum test, and positive anti-SS antibodies, starting pilocarpine plus levothyroxine for concomitant Hashimoto's disease. In February 2022, she had COVID-19 with fever, cough, sore throat. And 4 months later, her dyspnea of exertion and cough had continued. Then CT showed reticular shadow in her bilateral and she was referred to the Department of Rheumatology. Ovarian cancer, and she had no family history, social history, and allergies. Her body weight was under 40 kilogram, and she had no fever, but she had xerostomia and atrophy of tongue papillae were observed, and no cervical lymph node swelling. Fine crackles on her lower back was observed, and other manifestation was negative. The laboratory findings are shown here. Mild anemia and CRP elevation was observed, but other serum chemistry showed within normal range. About immunology and infection tests, she had positive anti-nuclear antibody with spectral and centromere type, and anti-SS antibody positive, but negative cryoglobulin or ANCA, or T-spot. This is the interferon gamma releasing assay. She had no desaturation at rest. Her chest X-ray showed reticular shadow in her bilateral lower lobes. ESS-DI was 23 points, including general, lungs, and hematology. Pulmonary functional test showed reduced vital capacity, and 6 minutes walk distance test showed 365 meters with decreased oxygen saturation level with severe dyspnea. Transthoracic echocardiography showed no pulmonary hypertension. I'd like to show the chest CT. This showed mainly reticular shadow and ground glass opacity on her bilateral lower lobes, shown here. Okay. We diagnosed her as interstitial lung disease in primary Sjogren syndrome after excluding other differential diagnoses. We started 40 milligram per day of prednisolone with rituximab for her moderate to severe ILD. Left side is baseline data, and right side showed 1 month later. Her pulmonary functional test, 6 minutes walk test, and chest X-ray showed improvement. Now she maintained stabilization with maintenance therapy. Next case was 65 years old female with dry cough from 1 year after the onset of Zika symptom with Sjogren syndrome. At baseline, ESSDI was 17 points, including skin, lung, and biological manifestations. She was diagnosed as Sjogren syndrome, ILD, and treated with 30 milligrams per day of prednisolone. This CT showed the left side baseline and right side 1 month later. As you can see, her reticular shadow in CT improved. This patient started concomitant immunosuppressants as steroid-sparing agent in maintenance phase. So I'd like to focus on the pulmonary involvement of Sjogren syndrome. The prevalence of respiratory tract involvement was 9 to 24%. If the patient have pulmonary symptoms, complete pulmonary functional tests plus HRCT are recommended. If these are normal, we should consider alternate etiologies like asthma, xerotrachea, cardiac etiologies, reflux disease, anemia, and thyroid dysfunction. If the tests are abnormal, manage according to the abnormality detected. About Sjogren syndrome, ILD, the prevalence increased from 10% at 1 year after diagnosis to 20% at 5 years later. This means the prevalence increases during the time course. The risk factors of pulmonary involvement were reportedly aging, male, smoking, and low C3, and positive anti-Rho52 antibody. This is a recent report. Other cohorts showed the only C3 was the risk factor shown in this heat map. And a retrospective study in China showed 10-year survival rate was 82%, like this figure. The EULAR recommendations showed the use of immunosuppression like cyclophosphamide or rituximab for the patient with high ESSDI, which was defined as highly active pulmonary involvement, such as ILD, with shortness of breath at rest or with abnormal lung function test. As this includes consensus-based recommendations, we may decide to try rituximab before using other therapies, depending on the individual patient, like cryoglobulinemic vasculitis. However, the available evidence to support the specific dose and duration of induction and maintenance therapy come mainly from retrospective data. This algorithm was from the published consensus guidelines for evaluation and management of pulmonary disease in Sjogren's by the Sjogren's Foundation in America. Therapeutic strategies are decided by the severity and speed of the progression. If the ILD is symptomatic and moderate to severe, moderate dose of oral glucocorticoids with MMF or azathioprine as first-line steroid sparing or adjunct agents are recommended. If the ILD is refractory, rapid progression or with respiratory failure, high-dose glucocorticoid with rituximab or cyclophosphamide are recommended. For progressive fibrotic ILD, antifibrotic drug administration is considered. Finally, glucocorticoids should be used at the minimum dose and the length of time necessary to control active systemic disease. Okay, let's move on to the next case with a 70 years old male. His chief complaint was dry mouth and purpura. He presented dry mouth and purpura on his lower legs on 2020. Skin biopsy showed leukocyte-clastic vasculitis, and it was observed with ointment in other hospitals. In 2021, gradually progression of renal dysfunction was observed, and renal biopsy showed acute interstitial nephritis. Then he was diagnosed as primary Sjogren syndrome by positive serum test, fluorescein test, gum test, and lip biopsy, showing green spans grade 4. On April 2022, the renal dysfunction continued, and he was referred to the Department of Rheumatology. Past medical history was CKD and chronic HPV infection with entecavir. He had no specific family history and social history for allergy. The laboratory findings shows that abnormal urinalysis with high level, like here, positive urine protein and blood, and high level of creatinine with normal anion gap metabolic acidosis. Hypergammaglobulinemia and hypocomplementemia and positive antinuclear antibody with positive SSA antibody, but negative cryoglobulin and negative ANCA. This shows the fractional excretion of sodium, potassium, uric acid. They are high, and alpha-1 microglobulin was also high. So his diagnosis was primary Sjogren syndrome with acute tubulointerstitial nephritis. ESSDI was 19 points, including skin and renal manifestations. About acute tubulointerstitial nephritis, distal renal tubular acidosis were observed because he had metabolic acidosis with normal anion gap, a normal urinary anion gap, and low FeHCO3. He started high-dose glucocorticoid, 60 milligram per day, prednisolone, for renal manifestations. After that, renal function was improved from 3.9 of creatinine to 2.7. As shown in this table, abnormal data shown in pink also improved after the treatment. We can see the acidosis, urinary sodium, potassium, glucose, uric acid, phosphate excretion were improved like this. The prevalence of renal involvement in primary Sjogren syndrome is about 5%. As pathophysiological processes, epithelial disease with mononuclear lymphocytic infiltration results in tubulointerstitial nephritis, and secondary immune complex mediated process results in glomerulonephritis. Hypergammaglobulinemia is associated with distal renal tubular acidosis and low C3 levels and cryoglobulins associated with glomerulonephritis. Distal renal tubular acidosis is due to inadequate hydrogen ion secretion in the cortical collecting duct by the acid secreting alpha beta carotid cells shown here. The underlying mechanism is that hATPase pumps are absent in immunohistochemical analysis of the kidney tissue, and autoantibodies directly against carbonic anhydrase 2, which is responsible for hydrogen secretion, are reported. This causes normal anion gap metabolic acidosis and often associated with hypokalemia due to urinary kalium ion wasting. This cell is preserved, so sometimes we experience the hypokalemia. And normal anion gap metabolic acidosis, the urine pH is under 5.5, shown here. This table shows spectrum of kidney disease in Sjogren syndrome. As I mentioned, tubular dysfunction due to interstitial nephritis cause hypokalemia, distal renal tubular acidosis, AKI to CKD. But Fanconi, Gitelman, and Bartter syndromes are rare prevalence. Autoantibodies, lymphocyte plasmacytic infiltration in renal tubules are suggested as underlying mechanism. Distal renal tubular acidosis may also manifest as nephrolithiasis or nephrocalcinosis, causing renal colic or urosepsis. Nephrogenic diabetes insipidus can also occur in Sjogren syndrome. Among glomerular disease, MPGN is the most frequent type, and the membranous nephropathy and globulinic vasculitis may also be present. If renal involvement is moderate by ESSDI definition shown here, glucocorticoid and immunosuppressive therapy is indicated. About immunosuppressive therapy, the lack of head-to-head comparison does not permit a recommendation on the use of one agent over another. If the urinary protein level is high, leading to renal failure or complicated by cryoglobulinic vasculitis, it is classified as a severe one, and rituximab or cyclophosphamide, in some cases, plasma exchange are selected as rescue treatment. Similar to the recommendations for lung lesions, the lack of evidence for organ-specific treatment for Sjogren syndrome means that these recommendations are of a consensus-based nature, and the choice of treatment should be determined by individual cases in accordance with the evidence in other systemic autoimmune diseases and discussed with the attending physician and core team. This is the summary. Targets of the management of Sjogren syndrome are divided into glandular and extraglandular manifestations. Treatment of glandular manifestations is mainly symptomatic. The choice of intensity of treatment of extraglandular lesions are determined on organ and severity, speed of progression basis for each patient. Disease monitoring is based on organ-specific assessment indices, referring to the description in the ESSDI. In pulmonary and renal lesions with high ESSDI, concomitant use in rituximab can be a treatment option in addition to RBCY in conjunction with high-dose glucocorticoids. Further evidence for organ-specific treatment management is needed. Thank you for your kind attention.
Thank you very much, Dr. Kikuchi. The wonderful and nice presentation. He showed in the first part, he overviewed clinical aspect of Sjogren syndrome, and in the second part, he focuses on the management of Sjogren syndrome, especially extraglandular manifestation. He showed the two cases, and one is ILD case, the second one is kidney disease, and with a comprehensive educational explanation. So very, very interesting. I learned very much. Later, I will ask Dr. Kikuchi, and if you have any, if a participant has questions, please use chat or in the panel discussion, please raise your hand. So thank you so much, Dr. Kikuchi.
Thank you very much.
And let's move to the next presentation. Next speaker is Dr. Suryo Angorokusumo Wowo. He introduced him. He is a rheumatologist and medical staff in Division of Rheumatology, Department of Internal Medicine, Cipto Mangunkusumo National Referral Hospital, Jakarta, Indonesia. After completing his medical school at Faculty of Medicine, University of Indonesia in 2006, he continued his internal medicine specialty and rheumatology subspecialty in the University of Indonesia. And he served medical service in the rheumatology area, and he has experience to going abroad in Netherlands. And now that he is a member of Indonesian Rheumatology Association and recently held the position of Secretary General of IRA, he was involved in the development of several clinical guidelines issued by IRA, and also actively contributed as representative of IRA in the development of government policies and health programs related to rheumatic disease in Indonesia. And today, his talk title is Overview of Recent Clinical Trial and Perspectives. Dr. Suryo, time is yours.
Thank you, Professor Suzuki, for the kind introduction. I would like to thank also the committee for the opportunity to talk in this meeting. My talk for today is about the review of recent clinical trials and perspective in Sjogren syndrome. I have no conflict of interest to disclose. So as mentioned previously, that Sjogren syndrome is a systemic autoimmune disease with a specific predisposition of causing inflammation of the exocrine glands, predominantly salivary and lacrimal gland, but also can involve internal organs. Some literature term it as autoimmune epithelitis or lupus of the epithelium due to the mechanism underlying the disease, which in some part resemble lupus. So it is found around 1% of the population with peak onset of 40 to 60 years of age, with the clinical manifestation predominantly on the exocrine organs, but can also involve internal organs. And to date, there is no drug approved specifically for Sjogren syndrome. And before we talk about the treatment, so this is just a simplified pathogenesis of Sjogren syndrome. It usually started with a triggering event on a genetically predisposed individuals, which then activates salivary gland epithelial cells, and that salivary gland epithelial cells can also produce cytokines and function as antigen-presenting cells, which then further activate the professional antigen-presenting cells, and furthermore activate B cells, T cells, and it resulted in inflammation and histologic changes of salivary organs or internal organs. And along the way, there are a lot of cells and cytokines that is involved in the pathogenesis. And all those cells, the communication within cells is target for new treatments. And also the intracellular signaling molecules inside of the B cells and other immune cells can also be target for new treatments. So previously, there are several randomized control trials on Sjogren syndrome, but majority of studies did not show positive results. There are reasons of that. First one is most of the studies are underpowered with low number of subjects. Some included patients with different phases of disease. Some patients included already have irreversible damage to the exocrine organs, and some patients are in an inactive disease condition. And the majority of the studies use unvalidated and insensitive endpoints. And the diverse mechanism involved in the pathogenesis is which are reflected by diverse clinical manifestations. So there are a lot of, let's say, types of patients. Here, I want to show you that along the way, there are some differences and similarities between clinical trials in primary Sjogren syndrome. So the older studies, like the infliximab studies or the Joker hydroxychloroquine studies, included patients with Sjogren syndrome without classifying whether they have irreversible damage of the Sjogren organs or not. But the newer trials, such as the rituximab, the TIRS and TRACTIS trial, limit the patient that they only included patient if they
Secretary, would you reconnect?
Yes, I think his connection has problem.
All right, we just wait. Yeah, I think he is now connecting again. So yeah, we suspect he has some problem in the internet connection. So we wait the more. Please wait a little bit. Sorry for participants. Miss Banda, Dr. Suryo was in the backstage. Oh, he came back. So please, Dr. Suryo,
yeah,
start again.
Yeah, please apologize. I
Yeah,
lost
it's
my
okay.
signals. Okay, so yeah, I think this is this my last slide? My last slide. Yeah. So may I repeat again that most studies in the past use and validate primary endpoints, and therefore the SDI was created is to measure systemic disease activity, and the minimally clinical important improvement is defined if the SDI is improved 3 points or more. But there are critics on SDI that some important manifestation was not included, and the biologic marker change may go undetected. Nonetheless, SDI and SPRI is used as the primary endpoint in most of the newer studies. So overall, these are the new treatment targets in Sjogren syndrome, targeting the B cell activation, the antigen presentation, and also the innate immunity in Sjogren syndrome. So the first one, we will see about the targeting B cells. There are several drugs. There is targeting B cells, the belimumab, the rituximab, and also the ianalumab. So the belimumab is a anti-B lymphocyte stimulator monoclonal antibody, while rituximab is an anti-CD20 that binds and depletes CD20 expressing cells. The limited efficacy of rituximab in primary Sjogren syndrome, beside the trial design, might be explained by that administration of rituximab will increase the level of serum bliss, and then it creates a reemergence of autoreactive B cells. And also the tissue resident B cells in microenvironment are less responsive to rituximab due to ectopic expression of bliss in inflamed site. This is a study in patient with lupus and RA, which showed that after rituximab administration, the buff level increased, and the increase in buff is followed by the increase in the repopulation of the B cells. Therefore, the combination of belimumab and rituximab might have additional benefit. So this is a randomized controlled trial which include adult patient with primary Sjogren syndrome, active systemic disease, which was given belimumab, rituximab, or rituximab only, or combination belimumab, rituximab, and placebo. The primary endpoint of this study is safety to week 68, and the adverse effect and adverse effect of special interest are the same between all 4 groups. For the efficacy, we can see that the belimumab and rituximab group showed reduction in the B cells compared to other groups. And for the clinical endpoint, there is a trend of decreasing in SDI and also a trend of increase in salivary flow, but did not reach statistical significance. And numerically, the belimumab and rituximab group, the yellow mustard group, showed numerically higher responder compared to other group, particularly compared to placebo. So this might be useful to do further phase 3 studies. The next drug is ianalumab. Is a monoclonal antibody designed to target human buff. It inhibits buff receptors. This is studies which include moderate to severe systemic primary Sjogren syndrome patient, and they were randomized into 4 groups. Those ranging studies with the primary outcome of change in SDI score compared to baseline. And this study also showed that the ianalumab group, particularly the higher dose, showed improvement in the SDI score, and the primary endpoint was met, although there are slightly more patients with adverse event with ianalumab 300 milligram. But this study is one of the first study which showed improvement or that reached primary endpoint in the Sjogren syndrome trial. Yeah, another new drugs that is being studied is telitacicept. Is a dual BAFF/APRIL inhibitor. These studies recruit patients with moderate severe primary Sjogren syndrome and randomized into 3 groups: placebo and 2 doses of telitacicept, with the change from baseline of SDI as the primary endpoint. And again, this study showed that telitacicept showed improvement in SDI and reduction in biologic markers, which is serum immunoglobulin levels, with no serious adverse effects. So the treatment for which targeting B cells showed promise for the treatment for Sjogren syndrome. Next is the small molecule targeting intracellular signaling pathways. There are several drugs that has been developed and trialed for primary Sjogren syndrome patient. There are leniolisib and seletalisib is the inhibitor of PI3K kinase. Filgotinib, a JAK inhibitor. Lanlapranib is the spleen tyrosine kinase inhibitor, and tirabrutinib and remibrutinib, the inhibitor of Bruton tyrosine kinase. Of all of these 5, only remibrutinib showed improvement in SDI score compared to placebo. Other drugs did not meet the clinical efficacy endpoints. Another groups of drugs that also new drug that has been developed is the drug which target the antigen presentation and co-stimulatory receptor. We know that to activate T cells or B cells, the first signal is the antigen specific signals. The second signal is the co-stimulatory molecules, and those co-stimulatory molecules may be the target for treatment. The first one is abatacept, is a selective co-stimulation modulator that blocks the interaction between CD86 on antigen presenting cells and CD28 on T cells. So this is a study from the Netherlands group, which include patients with moderate severe primary Sjogren syndrome, with the primary outcome of difference in SDI score. These studies did not show difference between both groups on the end of the trial, but this group showed high placebo response. Both abatacept and placebo group showed improvement in SDI. There is improvement on biologic markers and no death or treatment-related severe adverse events. This study is followed by the open-label trial for 48 weeks, and the patient who switched from placebo to abatacept showed additional reduction in the SDI score and also the ESPRI score. This is from the American group, which showed about the same, that the primary endpoints was not met with the treatment of abatacept. Another co-stimulatory blocking agent is iscalimab. It's a blocking of the CD40 ligand interaction. These studies, there is a small study with 2 doses of iscalimab with the primary endpoint of change in SDI score after 12 days of treatment. So yeah, the low dose of iscalimab, the 3 mg per kilogram body weight, does not show improvement, but the bigger dose, 10 mg per kilogram IV, showed improvement in the SDI score compared with the placebo group. And also the ESPRI score also differed only on the higher dose of iscalimab. Another co-stimulatory blocking agent is the prezalumab. It's a humanized IgG antibody targeting ICOS ligand. And these studies also recruit patients with moderate severe primary Sjogren syndrome. The primary endpoint was SDI score change from baseline to day 99, but this study did not met the primary endpoint. Another drug that interfere with the antigen presentation is cathepsin S inhibitor. So cathepsin is expressed in antigen presenting cells, and it is important in antigen loading. So cathepsin S is elevated in a lot of autoimmune condition, and petacicatab is an inhibitor of the cathepsin S, which reduce the MHC2 mediated antigen presentation. Patient was randomly assigned to 2 groups, placebo or petacicatab. These studies included patients with moderate severe Sjogren syndrome with primary endpoint proportion of patients who had 3-point reduction of SDI. And these studies did not met its primary endpoint and also all the secondary endpoints. So next is the cytokine inhibitor. Interleukin-6 is a potent stimulant for B cell proliferation, plasma cell survival, antibody production, and these studies randomized patients with primary Sjogren syndrome into 2 groups, the tocilizumab and the placebo group. These studies included moderate severe primary Sjogren syndrome, and the primary endpoint was response, and the criteria of response consists of three definition: decrease in SDI, no occurrence of moderate or severe activity in new domain of SDI, and no worsening in physician global assessment. 110 subject was being randomized, but unfortunately, across the time points, this study did not show difference between tocilizumab and the placebo groups. And this study, similar with the abatacept group, showed strong placebo response. The placebo group also has reduction in SDI, and the adverse event was more frequent in tocilizumab group. Another interesting new treatment is low-dose interleukin-2. IL-2 is the key cytokine that regulates the homeostasis and activation of CD40 cells. So IL-2 is needed for the proliferation of Tregs, and we know that Tregs promote immune tolerance. So the Tregs have a high affinity receptor for IL-2. If a patient was given high dose of IL-2, then other subset of T cells will be activated, but with low dose IL-2 only selectively support the proliferation of Tregs. And this study include patients with primary Sjogren syndrome, active disease, and randomly assigned to receive recombinant human IL-2 versus placebo. And the primary endpoint is improvement of SDI by week 24. 60 patients was being randomized. And interestingly, this study showed that SDI primary endpoint was met with patient receive IL-2, and the safety issue is quite good too. Okay, and this study showed that there are several outcomes which improve after given IL-2, the dryness and also the fatigue also improve. This is another new studies with old drugs, the leflunomide and hydroxychloroquine combination compared to placebo. Similar with other studies, this study recruit moderate active primary Sjogren syndrome patients with the primary endpoint of changes in SDI. This is only a small study, only 29 patients included, but this study showed that at the end of the study, there is a significant difference between patients who receive placebo and the leflunomide hydroxychloroquine combination, and improvement in the leflunomide hydroxychloroquine combination was shown in 7 domains out of 12 domains in SDI. And we can see that the unstimulated whole saliva also improved with the combination of leflunomide and hydroxychloroquine. Another drug that has been tried in Sjogren syndrome is iguratimod, a small molecule which is used as DMARD in several countries, and it has several mechanisms of action, blocking several cytokine and also blocking the development of plasma cells. These studies recruit patients with active systemic disease of Sjogren syndrome with primary endpoint APLAR score. And these studies also showed improvement, reached its primary endpoint that there is improvement in the iguratimod group compared with placebo. The last new drug is the RSLP132. This drug is preventing TLR activation. And these studies include primary Sjogren syndrome patient with interferon gene expression signature, with the clinical efficacy measure is SDI score. This study did not show improvement in SDI and APLAR score, but the study showed improvement only on fatigue. So we have seen that most of the studies use SDI and there are talks that finding another clinical endpoint which is sensitive enough to detect changes, and therefore then there are 2 new endpoints, the CREST and also the STAR, which will be validated in the necessary trial. Hopefully with this new clinical endpoint, we can see more positive result in new trials. Another thing that we should remember that Sjogren syndrome is a diverse has diverse manifestation, and like lupus, sometimes refocusing trials on some group of patients may be better than included all patients into the trial. And these studies showed that they stratify Sjogren syndrome patient into 4 subgroups: the low symptom burden, the high symptom burden, the dryness dominant with fatigue, and pain dominant with fatigue. Besides different clinical presentation, those 4 groups also have different biochemical features. And by applying those subgrouping, we can see that previously negative trials, such as the Joker trial, showed improvement of APLAR score on high symptom burden subset. So, and also the previously negative Tractis trial, the rituximab trial, with this subgrouping patient, we can see that rituximab significantly improved the patient with dryness dominant and fatigue patient. So probably this is the new direction for trials in Sjogren syndrome. So in conclusion, Sjogren syndrome is a systemic autoimmune disease with specific predisposition causing inflammation of the exocrine glands that also can involve internal organs. The pathogenesis is complex, involving various cells and cytokines, and those cells and cytokines may be the new treatment targets. There are new drugs who met primary endpoint in primary Sjogren syndrome, but several trials did not meet primary clinical endpoint, although improved biological and histological outcomes. So maybe better clinical endpoint is needed. So diverse manifestation in Sjogren syndrome reflected diverse mechanism of disease. Future trials may need to focus on some patient subgroups. And the search for Sjogren syndrome treatment is still on. I think that's all. I apologize for the technical issue. Thank you, Professor.
Thank you very much, Dr. Suryo. The very nice presentation and the wonderful overview of pathogenesis. The next part, he showed clinical trial, and lastly, he stated some problem assessment system of Sjogren syndrome. The new he shows the new assessment criteria. Thank you so much. The very interesting. I have many questions, so thank you very much. Okay, we would like to move to panel discussion. So we invited 4 speakers, so they showed very interesting ones. So I have many questions, but many questions we already received by the chat. So the first, Dr. Yoshimoto from Joseph Marzo. Okay, Dr. Yoshimoto. If IL-6 is thought to mediate the pathogenesis of primary Sjogren syndrome by synergic action with BAFF, would anti-IL-6 therapy, example tocilizumab, and anti-BAFF therapy, example belimumab, be of any benefit? So, what is your comment?
Thank you very much for your questions. And as Dr. Suryo presented his data about the clinical trial of tocilizumab for primary Sjogren syndrome, but the efficacy is not drastic. So I think the combination of some biologics, for example, anti-IL-6 antibody or BAFF or anti-BAFF receptor, I think the combination of the biologics are have more efficacy for the Sjogren syndrome because of the very complicated symptoms and pathology of this disease.
Okay, thank you very much. And do you have Dr. Suryo, do you have any additional comments on this about and IL-6 therapy and combination therapy?
Yeah, the IL-6 anti-IL-6 trial did not meet its primary endpoint, and it's quite surprising considering the importance of IL-6 with the B cells and inflammation in general. So probably, yeah, as Dr. Keiko mentioned, that the pathogenesis is complex. Probably the main driver is not the IL-6 itself. So that's why it's negative. And the combination, I think, although not significant, but the rituximab belimumab combination showed that probably combination may work. But yeah, I think need more data on that.
Thank you so much. So the 2 speakers stated the possibility of treatment for Sjogren's by anti-IL-6 and anti-BAFF. So thank you so much. So next question to Dr. Kikuchi. Really, how does low C3 increase risk for pathogen progression of ILD in PSS patients?
Thank you for your question. I have not exact available data about the generally low level of C3 and C4 related to the poor prognosis, especially extragranular manifestation in Sjogren. And maybe the complement consumption may contribute to the Sjogren etiopathogenesis. And someone suggest this low level may help improve the survival of autoreactive B cells. So I think this pathology is related to the progression of ILD.
Yeah, thank you very much. Okay, the next question to Dr. Kikuchi. Can I ask with regards what would be the maintenance therapy of choice for PSS extragranular manifestations?
Thank you very much. The recommendations suggest azathioprine or MMF or calcineurin inhibitor, but maybe methotrexate used for arthritis, for example. There are no head-to-head studies, so we use this as a purpose of steroid-sparing agent. However, we have to take into account insurance coverage in different countries.
Yeah, thank you very much. Very comprehensive answers. So, relating this question, I would like to sum to Dr. Kikuchi. And in your first case of your presentation, Dr. Kikuchi showed ILD cases. So in that case, what kind of drugs in the maintenance therapy?
Thank you very much. In this case, the maintenance therapy is rituximab injection, maybe 500 milligram per half. Yeah.
Okay, the first induction prednisone high moderate dose and rituximab induction and continues low dose prednisone and rituximab maintenance therapy. Is that right?
Yes, that's right.
So at this time, so is this effective to keep maintenance?
Yes.
Yeah, to keeping maintenance for the patient.
Yeah.
Okay, thank you so much. The next question, Dr. Kikuchi. How about the management of patients with Crohn's disease in PSS? That is from Nanding Elden Danzem. So sorry about this.
Thank you. Thank you very much. I have no specific experience in this situation, but it's important to set the target of the treatment and the goal of the treatment.
Yeah.
So I think we should share with the gastroenterologists.
Yeah. Crohn's disease is a different disease from Sjogren syndrome. So, Dr. Suryo, do you have any comments on this Crohn's disease in PSS? Difficult questions.
Yeah, I think it's difficult to answer because I think we need to see what kind of manifestation of Sjogren syndrome, and then I mean, and also how severe is the Crohn's disease. So I think the treatment should be discussed and yeah, with the gastroenterologist. I think it's difficult to answer.
Yeah, thank you so much. The next question, maybe Dr. Kikuchi. Hello, excellent presentations. I wanted to ask if a patient is having only low positive, no evidence of any symptoms of Sjogren, but presents with gangrene of the toes of the feet with vasculitic ulcers and also bilateral wrist drops, suggesting neuropathy. How would you manage such a patient?
Okay, thank you very much. This patient, we cannot diagnose as Sjogren And I think this patient has small to medium vessel vasculitis.
Yeah.
So the differential diagnosis is SLE or polyarteritis nodosa, like that. So we should evaluate the whole body vasculitis, including gastroenterologic vasculitis by CT angiography, like that, in angiography, and we should maybe we should try to start high intensity of immunosuppressive therapy, but we should rule out the broad disease, including infection. Thank you.
Okay, thank you very much. Dr. Suryo, is there any additional suggestion for this patient?
Yeah, I agree that we should exclude infection first, because a lot of infection can produce can induce the secondary vasculitis, and also probably beside immunosuppressant. I think those kind of cases probably, yeah, I think needs high dose steroid as well with immunosuppressive. But
Yeah.
I agree that a lot of things needs to be excluded.
Okay, thank you very much. The next question, in maybe Dr. Kikuchi, or in ESS dye, there is a biological domain which include hypocomplementemia, low C3 or C4. What is the mechanism of hypocomplementemia in Sjogren? Is it similar with the mechanism with hypocompletemia in the lupus?
Thank you very much. Okay. The previous reported data show the patient with Sjogren with low complement levels are more likely to develop SLE, and so I think there are some shared pathogenesis between Sjogren and SLE. Yeah.
Okay. A little bit difficult. Is any other comments from the faculties? Okay. Yeah, I think a little bit difficult. So the Sjogren and SLE has manifestations of C3 and C4. I think the mechanism might be different, but it's difficult to distinguish it. So, okay, the next question. Excellent presentation, Dr. Kikuchi. Do you have experienced patients Sjogren syndrome with negative SSA or SSB? How to make sure that the patient Sjogren double negative?
Okay, thank you. We experience the negative SSA or SSB patients, and the key diagnostic test is a lip biopsy. The lymphocyte accumulation over one focus is a key test, and also we should confirm the objective data about dry symptoms. So both of them are positive. We diagnosed as Sjogren.
Yeah. Okay.
Thank you.
Thank you very much. I agree with you. Dr. Takeshita, you showed in your presentation double negative and SSA negative and SSB negative. What is the characteristic of manifestation? Would you explain that?
I don't touch exactly, but some of the patients have ACA, and some patients have the SSP, systemic sclerosis like symptom, or maybe low frequency of hyper IgG or RF. That kind of patient has exist, but the pathogenesis may be different from SSA positive patient.
Thank you very much. So, do you agree with the biopsy with SSA and SSA negative and SSB negative cases?
Yes, I agree.
Yeah, in our clinic, so such kind of patients, we recommend lip biopsy for the diagnosis. So, okay, let's move to the next question. Dr. Takeshita, which antibody the most related to lymphoma in Sjogren syndrome?
Okay, thank you for question. Maybe I think lymphoma is in Sjogren syndrome is the result of the repetitive stimulation of B cell. And so the typical lymphoma patient is SSA positive, SSB positive, and high titer patient. But there are other study that the antigen specificity of lymphoma itself, B-cell lymphoma have own antibody, and antigen specificity was researched, and half of the lymphoma's antibody is rheumatoid factor. So rheumatoid factor is also involved in drive lymphoma. So maybe these two antibodies are most relevant, I think.
Thank you very much.
Thank you.
Dr. Takeshita, there are another questions from me. In your clinical practice, do you check some serological marker for detection of or detection of lymphoma? So the C3 and C4 is one of the marker risk factors. So in your practice, do you check some serological marker for the recognizing the lymphoma?
I haven't checked that. Maybe lymph node is another manifestation.
Okay. Dr. Kikuchi, in your practice, do you check some blood test for the malignancy? So it's a clinical important issue, I think.
Thank you very much. I don't usually check the malignant marker routinely. For example, soluble IL-2 receptor. This is a marker of lymphoma. So I always check the surface lymph nodes.
Yeah,
like this.
Yeah. Okay. The regular examination, you check cervical region by the examination. So that if the enlargement of the lymphadenopathy, so you will check the further examination.
Yes.
Okay. Okay. The next question is maybe Dr. Kikuchi, is RTA with renal impairment was manifestations of Sjogren present 6 years later with persistent raised creatinine and hypokalemia corrected with the treatment? Now, no other manifestation except raised creatinine and hypokalemia. At this moment, is there any role of immunosuppressive therapy?
Thank you very much. We imagine, I imagine this case, the creatinine is very chronic due to chronic irreversible lesion, but to answer this question, we should check the renal biopsy to check the activity of in kidney. But I think it's important to manage this patient as a CKD, like hypertension or like this.
Okay, do you have any additional comment, Dr. Suryo? No comments?
Yeah, I agree that after 6 years, probably this is a chronic process, and I think the treatment is for the CKD. However, the hypokalemia is still there, so I think we might also check the general the systemic activity of the Sjogren syndrome. So I think the raised creatinine, we probably cannot do anything about it, but probably maybe the hypokalemia might be, we can still do something.
Yeah, okay. Yeah, I agree with you. So no immunosuppressive therapy is needed. So the next question, Sjogren with small airway disease, maybe Dr. Kikuchi, the recurrent shortness of breath subsided by short course steroid diagnosed as a small airway disease. Now no active feature of Sjogren. Should we start immunosuppressive? The related questions.
Okay, thank you. Thank you very much. This patient is now in stable, so it's okay. But how dose is acceptable? How dose of prednisone is acceptable is the main problem. This maybe we can extrapolate from the SLE data. Large SLE data in Asia showed under 5 milligram dose of prednisone is associated with a good prognosis compared to 5 milligram or over 5 milligram per day of prednisone. So I recommend that this patient keep at least under 5 milligram per day of prednisone. If this patient cannot decrease the dose of prednisone, we should consider immunosuppressive as steroid-sparing agent.
Okay, thank you so much. And we have many questions, so but time is so limited. So we would like to close this symposium day 2. So thank you very much. The very nice presentation, Dr. Yoshimoto, Dr. Takeshita, Dr. Kikuchi, Dr. Suryo. So, and I also thank to the participants sending us many questions. So I would like to close day 2 course. Thank you so much. Thank you very much for your kind attention.
Thank you very much.